Dr. Hellings, this requires investments from the hospital. What's the benefit or the expected benefit for hospitals from this technology?
Well, it all depends if you're talking about academic hospitals with the intention also to train residents and fellows versus non-academic hospitals where other services are provided, and it's more about providing clinical care to the patients and not always training as a combined focus of activities. So I do think for academic hospitals where training is also mandatory as part of the activity portfolio, that 3D technology and 3D recording and 3D imaging is really the way forward for the future. And also the residents, they like it very much because they're all impressed by the quality of the images. And I must confess that during rhinoplasty, we even used it there to allow the fellows to have a better view. And sometimes I was even looking at the screen and not to the real life nose anymore because it looks so nice, and it's of course a fancy tool. But if we would have this debate with the younger generation, I'm fully convinced that they would be even more excited and positive than we are now, because we have been trained first using an endoscope, then in 2 dimensions, and now going to the next step might not always be as smoothly as possible for some of us, but I'm fully convinced that in the future this will change.
Dr. Constantinidis?
I think the big advantage for documentation and education, and this is a really advantage of the 3D technology, is that it makes for the attending, for the trainee, it is more realistic to see the anatomy, to see the relationships, to have a better feeling of the depth of the operative field. And all my residents say that we see now exactly the same that you operate. That means they have the attendee and the trainee see exactly what you are doing. In the 2-3 technology, we always, during surgery, had a question: what is the behind this anatomical structure? Is the anteroethmoidal artery, as Paolo said, is it near to this bulla or to this anatomical structure or to this tumor? So we have a better image and a better 3-dimensional stereoscopic view. And for education, for academic institutions, a must.
For the doctors who have experience with the technology, is it easy to convince your hospital to invest in this kind of tool?
I'm coming from Crete, Greece, and we are still on crisis, and I don't think it is easy to persuade the local authorities to invest, at least in nowadays. But for educational purposes in an academic environment, I think that in the next few years it would be easier, especially if you prove that younger generations of surgeons would have probably a benefit from this technology.
Dr. Carrie?
So, working in a sort of socialised healthcare system, the NHS, and with the impending issue of Brexit coming up, I think we're going to struggle even more to convince.
That's not what they promised you.
I'm a realist. I think the challenge here is that we're competing against so many other demands in a health service. So if your surgical department is considering purchasing a robot, for instance, then the argument is relatively straightforward there. You can reduce inpatient stay, you can reduce patient morbidity, and you can do that on every single case. And you save money and you save the patient complications. The challenge here is that over a huge breadth of the procedures that we do, endonasal procedures, it's probably not going to make a huge amount of difference in terms of morbidity. It's going to cost more, but it's not going to make a great deal of difference to the patient. And measuring the benefits in terms of reduction in complications is very difficult because our complication rates are actually pretty small generally, as in any case.
I just would like to come in with another thought, and that is, some of us say, well, there are certain indications like skull base and above and so on, okay, and others say, well, we should use it everywhere. And then my question is, would you also have it 5 times in your ambulance, where the patient comes in because you want to look the first time with a 3D. So where do you start? Where do you stop? And I see that instrument not really completely replacing 2D, certainly not, but at certain indications where it really is an advantage because of the cost price. And I think also because of you have to learn the handling with it, which is not as easy as 2D. And we are very experienced, but look at the young people with 2D, they even struggle with 2D. So I think we have to find a balance here and not just overrun everything with a new technique here.
But still my question is, how are you going to convince your hospital authority to invest in it if there's no, at this point in time, no real evidence that the hospital will benefit from it? Dr. Leunig?
Yeah, I think there are two possible answers. Maybe teaching education is a very important topic. So this is a basic for more medicine, good outcome. So this could convince the hospital to buy this system. The second is the reputation of you as a surgeon or you as a center could as well be much better. But this raises another question, how to assess and how to estimate your success. So databases would be necessary. So this is it's a process which is coming on. But I think these two things could convince. But it's a hard fight, of course.
Mm-hmm. Dr. Castelnuovo, how do you measure success?
Well, when I discuss with the administrator, I don't want to discuss on economical issue only. For the hospital, the benefit is not only economical. So for the hospital, the benefit is also the improving of the precision of my surgery. So I fight for that. My role, I'm a physician, so not an economist. I accept the new rule to run through the expenses and so on, but I want to emphasize my role of physician. So if I have a tool that gives me an improvement of the precision of my surgery, I fight for it. Of course, I have to decide because I cannot buy everything, and the administrator is very tough in discussion, but I have to choose. I want this device for the measure, of course, not in all the settings, but I have to start to use every day. So, because I believe that giving me a better image improve the quality of my surgery. This is my discussion with the hospital.
Dr. Molteni?
Yes, speaking from academic point of view, there is another point to consider that the hospital have visibility and the university want to improve also its prestige. So if you have a new tool, new technology, more residents want to come to that university and even more patients want to come because today patients ask for laser surgery, even then sometimes they don't even know what is laser. But they ask for laser surgery, 3D surgery, robotic surgery. So this is also an economical improvement that the hospital can have. So we have to consider all this stuff. And another comment that in our specialty, in ENT, we have to deal with laser, microscopic surgery, robotic surgery, now 3D surgery, endoscopic. So we have many tools, and so we spend a lot of money. So that's the problem sometimes.
Dr. Hellings, are patients demanding for new technologies?
Well, they are at least impressed by novel technologies they have not heard before. That should not be a criterion, of course, to buy expensive and fancy tools, but it might put yourself as a surgeon in the forefront of novel developments. And this is also a discussion, for instance, on robotic surgery. I think you mentioned it already. In the field of abdominal surgery, urology, and neurosurgery, robot surgery is now becoming a kind of standard of care in some domains. And we cannot be always running behind the novel technology. So we should also, as a community and as experienced surgeons, be at the forefront of novel developments and embrace these novel technologies and not kind of be too skeptical. We should just embrace them, see what is the future position, and then recommend the use in specific or more extended cases. That's how I see the future.
Talking about novel developments, you already referred to more 3D opportunities in your field of expertise. Is it your opinion as well, dear members, that 3D is now the new way to go?
That was a very good example by Professor Hellings. Talking about 3D technology in nose and sinus surgery, I think that we should extend our thoughts to, for example, applications in rhinoplasty procedures. For example, 3D printing in combination with new scaffolds. What type of scaffolds can we use with or without cells? Things like that. And I think that in the near future, in an academic environment at least, all these applications must be taken under consideration. And at least in our department, we have a setup doing research, basic research in scaffolds, and applying stem cells or without stem cells, and 3D printing for future application in rhinoplasty. That was an excellent example. 3D technology doesn't have to do only with new devices for sinus surgery, but it is something furthermore.
Dr. Leunig?
I think it's already a part of our, surgical equipment, and I think you can't stop it. Not in every hospital, but in some are starting, and depends on the, reimbursement. It depends on the price, the cost. So, I think this is a process. It will be available, and again, I don't think you can't stop the train. We are on the way using this technology for more precision surgery.
Dr. Constantinidis?
I also think we have to stay on the horse. We have to follow the evolution. And especially in my country, as working in a university department and being responsible also for education, it's a must, I think. And because there is a competition between the private sector and the public sector, everything is new in technology and everything is new in medicine. First, the private sector, the private clinics try to buy it first, and then to say we have the best equipment, we have the best technology, so you have to visit us. And I think we have to fight for, we have to stay on the horse, and as Paolo said, we have to try it and see what is our experience, what are the results after a few years using and after having experience in this field.
Dr. Carrie?
I suspect if the early adopters continue to use it and then the masses fall in behind and find it's a useful tool, then there'll be a trickle-down effect. And with the cost coming down and with junior staff coming in and using this perhaps as the norm, as a new norm, then it will inevitably become the new norm.
Dr. Hellings, what are the implications of this new 3D technology on the education?
Well, I think it has been touched upon briefly by other experts as well, that it allows the fellows and the observers watching you doing sinus surgery to have a better view on the anatomy and to better understand the different steps of sinus surgery. I think that's very clear. It's an added value looking at 3D images and 3D videos and 3D real-life situations compared to 2D images. So that's very clear, and that does not need any further study. I think that's just common sense.
Dr. Castelnuovo?
Well, I think there is some critical issue in this regard, and we have to push the company to improve the quality of the setting, because one thing is that nowadays to record the image we get with the 3D is more difficult, and then to project in the congresses our 3D image is more difficult. Sometimes the evolution of the technology is not uniform. What changed really in the last few years is the quality of the camera, we already stressed, and the quality of the image. What it is not so easy and not at the same level is the recording system and the projecting system. Because everybody of us to teach, we need to record our images and to show to the audience. And this is still time consuming, still difficult. So this is one thing we need to improve.
Dr. Leunig, do you see other challenges?
Yeah. I think, Paolo, this will change over time. It will improve and the data load will be manageable. So this will take time, but it will improve. But concerning your question about teaching education, when you look in the literature, you see that young fellows, trainees who were trained or had the 3D model, they had a great benefit when they did it further with the 2D system. So the learning curve was really flattened and much quicker compared starting only with the 2D system. And even the experienced surgeon had great benefit even when he was trained for long years, when he used the 3D system. And when I do my surgical procedure, I mean, it's just a different world when I use the 3D system. It's a different anatomy. I mean, it's fantastic. It's precision. Yeah, it's very detailed.
Mm-hmm. I thought we just said start in 2D and then evolve towards 3D technology. Do I hear you say now that it's better to train people in 3D and then let them work?
No, but
2D?
there was a study which was done with young fellows, and they were usually trained first with the 3D. They looked how did they perform when they used the 2D, and they had a benefit then from the 3D for the 2D system. So, I mean, this is another concept which can be used.
I think I have a comment. We have only to look about children with the video game. Now they have video game in 3D, and they enjoy much more. And this is the evolution. So, of course, since the system is ready to give us enough quality, we start.
Is this also a bit about boys and their toys?
Of course. No, not really, but you have to be interested in new technology, and I mean, you have to take it easy and you have to use it as often as possible. The same with navigation. I mean, if you don't use it, you have problems by using it, and you're not safe, you're not trained, you're unsafe and unsure. So I would recommend to use 3D as often as possible and then make your judgment.
Dr. Bachert?
I just have one concern here, and I don't want to be the one with concerns. I mean, I'm absolutely sure that if that works great,
We need you.
then we have certainly indications for it, no doubt about that. I just doubt that it's the thing for everybody. And the question is a little bit, where do we start with it? Where is it really absolutely necessary that we need it in the future? Where is it just a nice gimmick? And are we at the end of the technology? You said we are now there. Or do we see in 2 years something else different? And we have seen a lot of changes over the time. Do everybody here feel that this is it and that will be it for the next 10 years? Can you foresee that with such an instrument as it is now, or maybe it can be improved in the future if you have it, that you can go along the next 10, 15, 20 years? That would be my question before I can tell my hospital, guys, that's what you have to buy.
Dr. Constantinidis?
If I try to summarize what was mentioned, we have first to learn the anatomy, we have first to learn the first steps to perform the first easy cases, let's say, and this is a tool that helps us if we have enough place up to now, that I would like to emphasize. If we have enough place, it works really good, it differentiates the anatomical structures. We have an excellent high depth of our surgical field, and we have to use it, and as Andreas said, as Professor Leunig said, and to take more and more experience, and then our brain will be have plasticity enough to adapt to this new equipment. So we have to use it. There are advantages in image and in precision surgery.
Dr. Carrie, to you, what's the biggest barrier in order to going to use this really in daily routine?
I think the initial barriers for me is it's a little bit like buying a computer. You look at the computer and you think, well, that looks absolutely fantastic. It's better than last year's. But if I know and hold on to next year, I'll get something that's just even better than that. And it's still bulkier. It's still more cumbersome than using a 2D system. And I would be, if I was putting a business case forward to my hospital at the moment, I would be thinking, let's just wait a little bit longer and see if the technology improves a bit more before I'm ready to invest in it.